Dear colleagues, in the setting of this educational initiative by EAHAD, I'm going to talk about ITI in the era of Emicizumab. My name is Carmen Escuriola-Ettingshausen, and I'm the director of the Hemophilia Center, Rhine-Main, Germany, Mörfelden. So this presentation is subdivided into 3 lessons. Part 1, focusing on immune tolerance induction, the standard of care, including the standard protocols. Part 2, pros and cons and unknowns of ITI today in the era of Emicizumab. And Part 3, focusing on these current new ITI strategies. So let's start with part 1, ITI in the era of Emicizumab in hemophilia A. So I do not have to tell you that the development of inhibitors in hemophilia A is one of the most serious complications due to repeated treatment with factor VIII. It usually occurs during the first 50 exposure days, predominantly in severely affected patients, and there is a strong correlation between inhibitor development and the underlying factor VIII gene mutation. Also, environmental factors may have impact on inhibitor development, and this focuses particularly on the intensity of treatment, which is done in the setting of severe bleeds or during surgery. Inhibitor development itself is characteristically characterized by a reduced efficacy of hemostatic therapy with factor VIII. So in conclusion, regular therapy with factor VIII fails. We have difficulties to achieve hemostasis and to perform surgery in those patients. And generally, we have to distinguish between transient, low-responding inhibitor patients, low-responding inhibitor patients defined with an inhibitor titer of 0.6 to 5 Bethesda units. The characteristic thing of a low-responding inhibitor is that it can be neutralized with high doses of factor VIII. And then we have the high-responding inhibitor titers above 5 Bethesda units, and here we cannot use factor VIII in the setting of bleeds or for surgery. And here we have to use typically bypassing agents, recombinant factor 7A or APCC, to treat bleeds or to cover surgery, or Emicizumab for prophylaxis. And this summarizes again the current treatment strategies. As already mentioned, we can use bypassing agents for acute bleeds and for surgery, high doses of factor VIII for the low-responding inhibitor patients, and for prophylaxis, we can use non-factor replacement therapy here, Emicizumab. Nevertheless, we still perform ITI immune tolerance induction, because neither bypassing agents nor Emicizumab are able to eradicate inhibitors. And once we achieve a successful ITI outcome with standard protocols or new protocols, we are able to treat patients with factor VIII again. How do these standard protocols look like? They include the regular and frequent administration of factor VIII. You can see as an example the Bonn protocol, high doses of factor VIII at a high frequency every 12 hours. And then we have in contrast the low dose protocol, lower doses of factor VIII, 25 up to 50 units factor VIII per kilogram every other day or 3 times weekly, and then the protocols in between. There are more aggressive protocols, including particularly immune suppression, such as the Malmö protocol, and this protocol also includes an extracorporeal immune adsorption with a protein A column. And those protocols are more used to induce a rapid negativation of the inhibitor, and they are mostly used as rescue therapies when standard ITI factor VIII-based protocols fail. How does the typical ITI course look like? And you can see here that when we start ITI, we experience typically a so-called anamnestic response, which usually occurs roughly during the first 2 weeks. Sometimes this can be a bit delayed. And then we have a classical reduction of the inhibitor titer until the titer gets negative. So the negative inhibitor titer is the first important milestone. Afterwards, once we achieved a negative inhibitor titer, the next step is to achieve a normal factor VIII recovery, afterwards a normal half-life. And these are the most important milestones defining successful ITI. And this is how the complete ITI success is defined, which is, as mentioned, the negative inhibitor titer, a normal factor VIII recovery, and a normal factor VIII half-life. However, we also see patients who do fail ITI, and this is defined as a failure of the inhibitor to decline by less than 20% over any 6-month period after the first 3 months of ITI, or patients needing more than 33 months to achieve successful ITI. Of course, there are patients who do not achieve a complete success, neither they do fail, so we have a partial response or a partial success. This is where patients usually develop a negative inhibitor titer, but do not achieve normal pharmacokinetic properties. What is also very important to mention is that not in all patients complete success is sustained. In those patients who experience a recurrence of the inhibitor, particularly during the initial phase after achieving ITI success, we are talking about a relapse or an inhibitor recurrence, which is very important and where we have to react again. What is the typical outcome of standard ITI? It depends a bit on the ITI regimen, but roughly we can say, and we have experience for more than 40 years with clinical studies, but also with real-world experience, that success rates differ between 60 and 100% with the different protocols already mentioned. If we look at the median time to success, you can see that this is also highly variable. So particularly with a more aggressive protocol, such as the Malmö protocol, including plasmapheresis, of course, we can induce a very rapid success. Whereas the factor VIII-based protocols classically need a bit more. Also, the peak inhibitor titer of the patients seems to have a very important role. And here it looks like that the peak inhibitor titer seems to be a limitation for the use of the low-dose, low-frequency protocol. And here we have the data from the Dutch protocol, and you can see both the maximum pre-ITI titer as well as the maximum titer during ITI in both figures implies that inhibitor titer above 40 Bethesda units is very difficult to eradicate when using this low-dose approach. Nevertheless, the low-dose protocol seems to be highly effective. And this is particularly true when we talk about patients with good risks. Patients with a maximum inhibitor titer of less than 200 Bethesda units, young children starting ITI without a big delay. And this was the research question of the international ITI study, comparing in a randomized fashion good risk high titer inhibitor patients to be treated either with a low dose regimen or a high dose ITI regimen. You can see that the total success rate was 69.7%. The ITI success rates did not differ significantly between the low dose and the high dose arm, but a very important observation was that there was a significantly shorter time to achieve a negative inhibitor titer with the high-dose ITI protocol, which was 3.3 months in median, versus 10 months with the low-dose protocol. And during this phase where the inhibitor titer was measurable, you can see it here on this table, there were significantly more bleeds in the low-dose subjects compared to the high-dose regimen. In conclusion, what should be the typical indication to use a high-dose standard ITI protocol? This should be particularly done in those patients who have a peak inhibitor titer above 200 Bethesda units. Many studies, the international ITI study, but also the Bonn single center experience, the GITI and the OBSITI studies clearly showed that patients with a maximum inhibitor titer of more than 200 Bethesda units, that the use of the high-dose protocol is really beneficial. The dose and the frequency should also increase in those patients, of course, who overcome this inhibitor titer during ITI, but also patients who do not respond adequately during the ITI course, means that they fail to decrease with their inhibitor titer. So having in our mind that the maximum inhibitor titer is a very important predictor for ITI outcome, there are even more predictors for ITI, which includes the pre-ITI titer. Here we define a titer less than 10 Bethesda units as good prognosis, whereas a pre-ITI titer above 10 Bethesda units, sorry, this is a mistake here, is a patient with a poor prognosis. Also patients young at age and with a recent developed inhibitors less than 5 years are defined as good prognosis, the others as poor prognosis. Very important is also the fact whether patients start with their first ITI approach, so we call them ITI naive patients, or whether they are already ITI experienced. During ITI, it's very important to avoid any significant interruption of the ITI course, as an interruption particularly more than 2 weeks. And then there are uncertain predictors, variables, which are highly discussed, which is the source of factor VIII concentrate, the timing of ITI regardless of the pre-ITI titer, the use of additional immunosuppressives, intercurrent infections or surgery, the ethnicity, and the factor VIII genotype. So having in our mind the importance of the maximum inhibitor titer, you can see here the key conclusions and recommendations of the FIT group. This is the group, the abbreviation, Future of Immune Tolerance. And you can see the higher the inhibitor titer is, the more intensive ITI protocol is recommended. So there is a clear stratification of by the maximum inhibitor titer to the ITI protocol. Of course, it is clear this is the start of the ITI, and we have to follow up and to accompany this ITI course very carefully. And if we observe any failure to drop by at least 20% for a 3-month period, this is the situation where we should interfere, means potentially increasing dose or frequency or switching to another product or adding immunosuppressives. Nevertheless, standard ITIs are quite successful, but we have a new potent prophylactic agent called Emicizumab, which is administered subcutaneously. It is a bispecific humanized monoclonal antibody that replaces the function by the missing activated factor VIII by bridging factor VIII and factor X, and therefore restores hemostasis in patients with hemophilia A partially. And it's indicated for the prophylaxis in patients with hemophilia A with or without inhibitors. And we can see how effective this agent is here expressed by the very low annual bleed rate, which is less than 1, and also by the very high percentage of patients experience not a single treated bleed, the so-called zero bleeders. And the data are gained from the licensure study circle Haven. Now, having this in our mind, we can say on the one hand that immune tolerance induction is the only proven strategy to eradicate inhibitors. And we have standard ITI protocols with success rate between 60 and 100%. They are efficacious, and they are, I start again. But with knowing this, we have different immune tolerance induction strategies, which have been proven to be efficacious as well as safe. We have success rates with the standard ITI protocols between 60 and 100%. Nevertheless, we have this very effective non-replacement agent, Emicizumab. And with knowing that, the question arises, what are the pros and cons and unknowns of ITI in the era of Emicizumab? Do we still perform ITI as we did it many decades ago? And this will be focused on in part 2 of this lecture.